So for my individual presentation, my topic is COVID-19 and nurse burnout, and I'm the individual presenter, Arvind Balyate. So as an overview, during the COVID-19 pandemic, we all know that nurses played a key role in delivering direct patient care, as they also had to cope with intense emotional, physical, as well as cognitive demands. So the experience of providing care had significant consequences for nurses as well as the nursing profession, and one such problem was that of burnout. So our literature review focuses on understanding what is the main cause of burnout, identifying both primary causes as well as their consequences. So for our review, we first see a cross-sectional study and identify the primary cause of burnout, and then we examine a descriptive study to help quantify that burnout. So the cross-sectional study that we took in was done in Spain and was used to identify the main cause of COVID during the burnout during the COVID-19 pandemic. So the theoretical approach to understanding burnout was done from the perspective of a job demands resource model. So what is a job demands resource model and which principle does it work on? So the principle of a job demands resource model is that every occupation has their own risk factors and they can be classified into two types: job demands and job resources, which in turn can affect organizational outcomes. So the model also postulates that the well-being of its employees is due to the interaction between these demands as well as resources. So what are these jobs demands and what are these job resources? So job demands refers to physical, psychological, social, or organizational aspects which can sustain physical as well as psychological costs, while job resources are physical, psychological, social, or organizational aspects of the jobs that reduce job demands and stimulate personal growth. Now we have a table below which explains this, but how can we simplify this further? So to put it as simple as possible, job resources are those things which motivate you to work, which will make you want to come to the your workplace and do work, and they reduce job burnout. Job demands are, on the other hand, are those psychological stress which make you feel tired, which make you feel worn out, and they make you not want to work, and hence they contribute to job burnout. So for the design of the study, we used a cross-section study which looked at only one specific point in time. We used a tool called a G-power tool so as to calculate how many nurses we needed for this study to be accurate. And we assumed a medium effect size of 0.15, indicating that the strength of study relationship between the burnout and the factors was significant but not too large. So the p-value for the study showed that there was a 5% chance that the results could be due to chance, which is a standard threshold for scientific studies. The original sample size needed was 189, but the responses they received was 771, meaning that the results were even more reliable. The power of the study was almost 100%, and hence it was very trustworthy. And it was also important to know that many of the participants in the studies were females, 694 out of 771. So for our data collection, they used online questionnaires and informed consent was a major part of it. So 717 responses were recorded out of the 1975 forms which were sent, accounting for a total of 39% response rate, which is pretty good. And there were 16 items on the questions relating to the scales of burnout. So this table talks about the mean, standard deviations, and correlations between variables. And over here we can see at number 6 it talks about burnout, and number 13 talks about perceived threat of COVID. So the x-axis shows the numbers for how they relate to the y-axis, and as we can see in the circle over there, perceived threat of COVID when related to burnout showed positive correlation. This was further built upon by the hierarchical linear regression analysis, in which we see that with each model these variables are added to see how they overall impact the model. In model 3, when perceived threat was added, it was seen that there was a positive beta value, or a partial, which represents a partial correlation, indicating that this was significant. And when added to model 4, it had a value of 11.34, showing that there was a high partial correlation between the predictor as well as the dependent variable. It was also interesting to see there was a negative correlation between social support and PTC, which can be seen in this table, the graph, which is an asymmetrical graph, which showed that when there was no social support, there was only a little bit increase from the mean value for +1 standard deviation. But at the same time, when social support was provided to nurses in the form of -1 standard deviation, there was a large scale decrease in burnout. So for nurses, what is exactly risk perception? So risk perception for nurses or people refers to beliefs and feelings in relation to possibility of disease or other harms to health. In a study done by Coe et al. In 2012, they identified three key constructs of healthcare workers' risk perception with the organization. This includes personal health risks like damage to oneself, social isolation, communication barriers as they're not able to talk to their peers, and risk to others. That is the transmissibility of the disease to their family as well as their friends. Now, in a study which was done by Lam et al., 5 overarching themes were used for nurses' perception of risk. This was novelty, the emergency infection disease scenario, severity, impressions of the impact of disease on public, proximity, how far the outbreak is from them, complexity, if there were multiple strains of the disease, and response, how was the government responding to these diseases. Now we go on to our descriptive study. The descriptive study entails many variables such as stress, depression, as well as burnout, and based on that we used the following scales: personal information form, perceived stress scale, Beck depression inventory, and Malsh in burnout inventory. So this table talks about the mean values, talking about how many of the patients or the participants felt mild, medium to mild forms of stress, depression, personal accomplishment, depersonalization, and as well as emotional exhaustion, with some of them feeling severe forms of these forms of variables as stresses, as including personal, as we can see for stress with a maximum value of 56, depression with a value of 63, personal accomplishment with a value of 32, depersonalization with a value of 20, and emotional exhaustion with a value of 36. Now we look at this table, which gives us a better understanding of how each scale works and how each variable relates to that. Now we see that there are bolded values in the table, and that's what's significant to us, and that's what I'll be individually talking about for each and every scale. So for the perceived stress scale, we look at years of experience, types of institution, and competence in patient care. Nurses with 1 to 10 years of experience, nurses were working in private sector, as well as those who felt that their competence report showed that they were not competent enough, showed that they had higher forms of stress. This was also complemented by a study which was done in Wuhan, which found that being a nurse was the only child in the family, and those who are doing long working times per week showed more forms of stress. Now we talk about the Beck depression inventory. For the Beck depression inventory, education levels and COVID-19 test results were the main determining factors. Graduates had slightly higher depression scores than postgraduates, and those who tested positive for COVID-19 also showed higher forms of depression. For the March burnout inventory, we look at the individual columns of personal accomplishment, depersonalization, and emotional exhaustion. So for personal accomplishments, we see that graduates reported lower forms of personal accomplishment as opposed to postgraduates. Nurses with an experience of 1 to 10 years of experience showed the same, as well as those who did not volunteer during the COVID-19, and they felt pretty unfulfilled with what they did. As for depersonalization, nurses again with experience of 1 to 10 years of age, or those who were working in private sectors, and those who did not volunteer during the COVID-19, they felt depersonalized as they were not able to communicate with their peers. For emotional exhaustions, it was seen that males reported a higher value than females, which is not commonly seen. Nurses who did not have an experience of 1 to 10 years, those who were working in private sectors, and those who did not volunteer, also were mainly haunted by higher emotional exhaustion. Finally, we come to the unanswered question. So some of the unanswered questions are as follows. How does the experience of burnout and stress differ across a various demographic groups such as gender, age, beyond the predominantly female sample which we have used in many of the studies? This is because nursing is a profession which is saturated by females in general and does not represent the male population, so there should be more studies which talk about that. Can future studies establish a causal relationship between perceived threat of COVID-19 with job demands, burnouts, rather than just talking about correlations, about making sure that one is the cause for the other? Another one which we can talk about is what are the most effective interventions to reduce burnout in nurses, and how do different resources influence these burnout levels, such as you can use social support training, how do they actually affect burnout? And the last one is what organizational interventions can reduce depersonalizations, those things on the March burnout syndrome that we saw, how can we actually reduce that? We need to talk more about that. Thank you.